Assalamu alaikum, the communication day. First scenario, Mr. Paul, 70 years old, was admitted with fatigue and weight loss. He had a CT chest abdomen and pelvis done, which revealed a renal mass, likely renal cancer. The plan was to get a CT renal and discuss in multidisciplinary team. He is in the hospital and was waiting to hear about the scan results and the plan going forward. Speak to the patient and tell him about the plan, address the concern. You can start.
Hello, I am Dr. Muhammad. I am one of the doctor in here today. With me, Mr. Paul, 70-year-old.
Yes, I am. I'm Paul.
How are you, Mr. Paul?
I'm very anxious, doctor. I mean, obviously, because I had a scan done 2 days ago, and I'm very anxious to know about the results. Everything okay?
Yes, your word is valid, and I am concerned. Mr. Paul, firstly, I need to confirm also, do you need anyone to be with us in this meeting?
I'm fine. I mean, why you asking? I'm fine otherwise.
Can you tell how much do you know about your condition, firstly?
Yeah, I mean, I was admitted because I had noticed recently that I have been losing weight and I was feeling very tired and fatigued. So that's why I was admitted because the fatigue was quite significant. So yeah, and then they said that we need to do some scans, and that was done day before yesterday, and I'm just waiting for that. So is it everything okay, doctor?
What do you expect, Mr. Paul, about this scans?
I'm very worried about that. I mean, because no one has spoken with me, so I don't know if anything concerning for me. Because yeah, so I'm very worried. So I don't know that. Can you please tell me that what exactly are the results?
Yes, Mr. Paul. The imaging, it is with me now, and I afraid to tell you that there is something concerning there.
What do you mean by this, doctor?
The CT, the imaging showed there is some growth there in your kidney.
Growth. What do you mean by that?
The growth means there is some suspicious uh, growth there in your kidney.
What do you mean by this? Suspicious. I'm unable to understand what you are saying. Can you please tell me a little bit more? What exactly you mean by this? I'm
Yes,
sure
yes.
it is not a cancer, isn't it?
That's why we are here today to discuss this issue, Mr. Paul. We have this alarm sign that you have weight loss and fatigue. All this alarm sign this make us alert about maybe some problem there. We did imaging all over your body, and we have seen this mass in your kidney. And mean suspicion mean we need to rule out any cancer there. Are you with me, Mr. Paul?
Yeah, I have cancer of the kidney. Oh my God.
لا, sorry, Mr. Paul. I didn't confirm that there is a cancer. I am telling this there is a suspicion. We are not sure until now. It is not clear. We need to do something to confirm this or to rule out this.
So you already did the CT scan, doctor. So are you not still sure what's going on?
Yes, Mr. Paul. Until now, it is only unclear. There is something suspicion there, a growth there in your kidney, and the team here decided to do another more detailed scan called CT over kidney and CT renal. And this is a special scan for the kidney. It will give a detailed map and more accurate information about this mass. Are you with me, Mr. Paul?
Yeah, but you already had me scanned 2 days ago. So, I mean, wasn't that enough?
I am sorry, Mr. Paul. I know it is too much scanning and maybe more hard for you, but until now, we are not sure what is mass. So the consultant and our team here sees that the best interest of you to give another more detailed scan to start our early treatment and our early intervention for this mass. So, Keith, what do you think about this, Mr. Paul?
Well, I mean, obviously, I'm upset because I wasn't expecting this. So I'm very worried now, rather more worried because you think that I most likely have a cancer.
Your worries is valid, Mr. Paul, and I know it is difficult, but we are here now to support you, and we are here now to put the plans to see what is the problem there. And I'm confirming again, we are not sure until now what it is mass, it is cancer or not. We are not sure. That's why the consultant request and plan for another more detailed scan to help us to make sure what is this mass. What
Right.
is
So after, right, okay. So you will I mean after the next this scan which you are saying about my kidney, then you will be sure that I have a cancer or I haven't had a cancer, right?
I appreciate your knowledge and your concern, Mr. Ball, but it is early to say about this. Sometime it can give us a clear information and to go straightforward for the treatment. And there is another uh, patient can be not clear again, and we may need another more invasive intervention or to make conform about it.
Mm. Doctor, I'm very upset because I had the scan done 2 days ago, and if it is something that serious, why I'm in the hospital, so why you didn't speak to me when the scan was done? Because I had the scan done 2 days ago, so if it is something that serious, you didn't bother to speak to me then. I mean, this is not a good thing.
I am so sorry and apologize if there is any delay in talking with you, Mr. Paul. Uh, but until now, I will look into this and I will see what's happened. Maybe sometime the reporting is delayed. Maybe sometime still the decision not taken. So I will check and look into that, and I will come back to you about this issue. And I apologize if there is any delaying for this issue. It is not intended, I'm sure.
Right. So when I'm going to have the another scan?
We are now uh, we are now making an appointment as early as possible. We'll contact the radiologist, the imaging room, and we'll do it as soon as possible, Mr. Boyd. It's okay for you?
So if you confirm after that other scan that this is a cancer, so what is the way forward for me? I'm very worried now. I mean, this is obviously quite scary.
Yes, your worries is valid, and I know it's difficult for you, Mr. Paul. This time is difficult, I know. We are here as a team, all the team will here, surgeon doctor, and kidney doctor. They will sit after seeing the next imaging and put the plan. We hope it's not a cancer. We hope this for you. But if it is that, there is many options for treatment, sometime by chemotherapy, radiotherapy, sometime by surgical. And I'm afraid to tell you, sometime maybe the kidney need to be taken away and removed.
Oh my God. Oh, so
2 minutes left.
yeah, this is, I mean, doctor, it seems quite a serious problem, isn't it?
I know it is difficult and hard for you, Mr. Paul. Yes, it is difficult, I know. But as early as we do the treatment for such issues, it will be more safe for you and more better in our treatment plan. For you,
Mm.
Mr. Paul,
Yeah, at least I know the plan that what exactly you're going to do. So yeah.
any, any other concern regarding this?
I mean, obviously, till the time you didn't get the scan, I think that at the moment, obviously, you are not sure what exactly is going on. So it seems that I just need to wait here.
Will be under our observation and our monitoring. until we did it, and I am assuring you it will be very soon. We'll contact by myself for the imaging department to make it as early as possible. For now, Mr. Paul, anyone depending on you at home, you need any support?
Yeah, I mean, I'm the sole earner of my family. So obviously, I'm in the hospital now for the last few days, and you are going to keep me in for another few days. So yeah, my family has been definitely affected by this, and obviously, I'm worried as well if it comes out to be cancer, as you're saying. So definitely, I'm pretty concerned and worried about my family as well.
We can contact our social team and we'll contact with the family and we'll see how can we help about this issue until we confirm our treatment. Okay?
All right, okay, thank you.
What's your job, Mr. Paul?
Yeah, I'm driving an Uber. I'm a driver in Uber.
Okay, okay, Mr. Paul, we'll give you some our occupational health also will help with this issue. Any smoking or alcohol, Mr. Paul?
Yes, I do smoke occasionally, maybe a cigarette or two.
You know, Mr. Paul, this smoking is very harmful for the health, especially in such situation. So I encourage you too much to stop it, and we can help you by smoking cessation clinics. Okay,
All right, okay.
I will give you some leaflet and website to read about this issue, and until we finish our imaging. Okay, Mr. Paul.
Mhm. So, what type of brochures are these which you are going to give me?
It will be about suspicious masses on the kidney and what will be and how can we will deal with it.
Okay, all
Okay,
right,
time is up.
all right, thank
The
you.
comment, yes, based on the skills in the chat box.
All right, okay. I think that you did very well. So, clinical communication, I think that was pretty fine. The only thing which you touch at the end, and you were saying that we are going to give you some brochures about renal masses. I don't know that there are any brochures about renal masses. There are brochures about specific diseases like a renal cell cancer or a polycystic or a medication. So I don't know because it's too premature to say whether exactly the patient had a cancer has a cancer or not. So I think that's something I don't think that was appropriate to offer. So I think that's the only thing. I think otherwise you covered very well everything. You didn't ask about the alcohol history, only smoking history was asked. Maybe you can ask about that as well. You offered support in that. So I think clinical communication was okay. Your clinical judgment was fine. uh, the only thing I think that regarding the treatment, I think that it's better if you can just you mentioned that, but in that same time you said chemotherapy, radiotherapy, surgery. So you can just put it to a multidisciplinary and tell that there will be a cancer team in that, and there will be a urology team, which is a kidney doctor, and all these things. And they can, because at the moment, even if it turned out to be a renal cancer, still, we will not be sure about the treatment because most likely he will need a workup to look for metastases which have not been done. So it's too premature to say that he will be a candidate for any of these things. So you reassured before knowing that what exactly is the extent of the problem. So if it is a kind of a renal cell cancer and if you do scanning and it already turned that patient have a metastasis to the spine or somewhere else, in that case it'll be unlikely for any kind of curative treatment. So whatever they are going to do, it will be a palliative. So I think that I feel that it is little bit kind of a false reassurance which you gave that don't worry, there have been treatment available and all these things. I think yes, you can say that at the moment we are still not sure about the diagnosis. So first of all, we need to confirm your diagnosis, and if it turned out to be a cancer of your kidney, then we'll need to do a workup to find out if it is just localized to the kidney or it has spread somewhere else, and just involve the team, that there will be a team of doctors. And once your investigations are completed, then they will discuss and find the best management plan about that. So just reassure in that way rather than saying there are a lot of treatment available and all these things, because you don't know, he might not be a candidate for any of these treatment and then might just be for a supportive care. uh, I think concern you manage very well, because the patient was mainly concerned, one about the diagnosis, which you handled very well, and the other thing was about effect on the family, because there were a lot of dependent and he was the sole earner. So I think that's you manage very well, and I don't think that there was any issue in terms of harming the welfare of the patient. So overall, I think that it's very good. So I'll give satisfactory in all these components like concerns, welfare, communication, and I think only that one thing which I've already just kind of a false reassurance. I think that it was too premature. So in that, I will put you as borderline. But otherwise, I think it was pretty okay. I think that was fine. Very good. Thank you very much.
Yes, perfect. I agree. You can get the full marks in all skills, Dr. Muhammad. But in the part of the term of mass, you mentioned overgrowth, mass. You can say also shadow. So we have shadow in your kidney, which is not clear for us. Is it cancer or something else? And again, the possibility is still possibility. He asks you, is it possible? Yes, it's possible to be a cancer. Be honest by saying this. Okay. The reassuring here, I think it was the cancer is not spreading because we have done CT cap, chest, abdomen, and pelvis. If there is spreading, it will be there, right?
I take this point as he need me to
Yeah.
يعني it is to take some option of treatment to assure him.
I think
Yeah, that's
again,
why.
I
Yes,
think that
it's
yeah, I
yeah.
think that I mean, if you can take it like this, that's fine. But I think that still patient haven't had any CT head done. You don't know about that. Patient haven't had any bone scan done. So there were a lot of things which were, and still there is no confirmation of the diagnosis. This is another
You are
point.
right, Dr.
So
Hisham. We can add to our my comment to him or my answer to him. Sometime maybe no treatment will be available if we found any spreading anywhere. But يعني your answer also is very good. We can tell that no, until now we are not sure. We'll wait until fulfill our workup. Then we'll come back to you after our group of specialists and consultant there, cancer and kidney and legs. As you mentioned, يعني we can deal
Yeah,
this
I
or
think this is the best way. No need to mention what are the possible option of treatment as long as you don't know what is there. So you can say we will sit together after that. We will discuss the possible management plan.
yeah, my point is, Dr. Basim and Dr. Muhammad, that this patient still doesn't have the diagnosis, right? And you are giving patient brochure about renal cancer. I think that's the one, because there is no brochure about renal mass or things like that. I don't know about that if there's any. So I think that's why my point is that you need to tackle it like that. There is a suspicion and we still need workup. So all these questions, they are pretty much premature.
I'm
First
not
we need
with
to
you,
find.
Dr. Hisham, regarding this. If he write in the if you are right now in the Google renal masses, it will write for you benign and malignant. He can read about this and this.
Yeah, so and that, then he's having a renal CT. So we're still awaiting the investigations part. So that's why I think that you need to, I mean, kind of a tell the patient at the moment we are not sure. So it might be a cancer, it might not be. Although on your current CT suspicion is high, but we need to, as you said, that you need a special CT scan only of your kidney, which is more specific to look into this, and that can guide us further. So just like this, so that the patient is aware, and then you can say that I can guide you on the further, because obviously we can guide you and we'll discuss in the multidisciplinary meeting, and we'll make a good plan whatever is most suitable, and then we'll have another meeting with you to decide what is the best way going forward for you in terms of your treatment. So I think, as I said, that you did almost everything fine, but this is the only thing which I feel that whether it was okay to just go and tell the treatments and all these things, since you haven't had a confirmation of the diagnosis. So that's the only thing I feel that maybe, I mean, as I said, that the examiner in the exam, they may not, they might say, okay, it's fine, no worries if you have tackled it like that. So I mean, my only point was that maybe it was a little bit too premature to just start telling the treatment options of renal cell cancer at this stage.
What I want to say also, always use the best interest in your talk. Doctor, I just have done the CT, so you can say again, in the best of your, interest of your condition, we have decided that you can do another CT or imaging to confirm this mass. Is it cancer or something else? And as well as for the management. In the best interest of your condition, the management plan will be discussed with the team, and we will update you in the next meeting as well. What I mean, this word will convince any patient if he's argued with you, or if he has any argument with you, why you are repeating. Is it important? I just have done one of the CTs. Whatever he will mention, use this word to convince any patient. The procedure itself, I think there is consent, Dr. Muhammad, you forget. Don't forget the consent form, okay? Because there is another separate consent for this procedure. This, I think, also what missed by you, and Dr. Hisham also didn't mention it. Let's go to the next scenario, Dr. Hisham, your scenario in the chat
Sorry,
box.
consent forms for the CT scan.
Yes, CT.
I don't think that this is common practice. I don't know whether because CT scan, I'm not sure, but that's something which generally not a normal practice here. So I don't
Practically,
know
we
what.
are not doing, and I
Yeah,
don't know. There is CTQB, CT renal, CT specific, any
yeah,
area you can
No,
do
no.
CT.
If there
yeah.
is protocol, a special protocol for a procedure, so they will give him contrast. Definitely, in this cancer or possibility of cancer, they are giving contrast. So I think there is
He should
consent form.
mention, Dr. Bassam, I think, should mention this in the.
Any CT for cancer, patient will receive a contrast. So no need to mention the consent form. This is what I believe in the medicine. Any procedure or any CT to diagnose a cancer, it will have a contrast. We will discuss this if you allow me to read the scenario, Dr. Hisham. Then we will discuss the consent or the contrast with other
Yes,
colleagues.
yes. Yeah, yeah.
Okay,
Sure.
so you are the registrar in the medical wards, Mrs. Catherine, daughter of Mrs. Carol, 84 years old, a woman admitted from the home 4 weeks ago with vomiting and weight loss. Blood tests don't reveal any obvious cause for the vomiting. Endoscopy showed mild gastritis. A CT scan of the abdomen was reported as normal. She is given esomeprazole 40 tablets once daily for her vomiting and has settled. She has dementia, which was diagnosed 6 years ago, was treated for 1 year with cognitive enhancer. However, her dementia has entered a very advanced stage, and despite assistance, she neither know how to eat nor show any interest in eating. She only takes small meals, amounts of fluid, sorry. She is not in any way feeling distressed. Your consultant feel that further aggressive therapy and investigation are not appropriate, and that palliative care is the best approach. Her daughter had come to the ward anxiously and would like to speak to you. The task to speak to Mrs. Carol, daughter, on your consultant decision and discuss any issue she raised. So we will give you some minutes, Dr. Hisham, to be ready. Then we will now we'll discuss. We should explain more about the renal CT. This is a good question, supposed to be mentioned during the steps. As any procedure, you can speak also about pre and or during, before and after, if you have the time. But if you cover the point of the CT, it's important. Okay, if not, at least provide the consent form at the end and tell him you have to be in the hospital, already the patient in the hospital, the precaution during and the area the patient will go, which is the imaging department, and some precaution before that because he might have allergy. The radiation also, he should be informed about the radiation he will receive, and so on. Dr. Soha, if CT angio, yes, need consent. Yes, I believe this sign, this type of CT need a consent because there is contrast. This is what I believe this patient will receive. Anyone has another idea from nephrology point of view? If there is CT renal protocol for a renal mass? So my opinion is a consent or the consent is essential in this scenario. No cancer will be diagnosed without a contrast. How to know the enhancement without taking a contrast? This is the point, Dr. Hisham and Dr. Muhammad, okay? If you want to diagnose a cancer or infection, suppose the patient will receive a contrast. So you have to speak about the dye, the side effect of the dye, and at the end you can speak about the consent form. The plain CT you are talking about, HRCT chest, high resolution CT chest, or CTQB. Yes, no need to sign a consent, but it will be just to rule out or to diagnose fibrosis in the lung, or to diagnose the stone in the kidney, or for trauma or stroke. So these types of CT, which is plain without contrast, doesn't need a consent. But any consent, any CT with contrast, like CT angio, to diagnose a hemorrhage or to diagnose aneurysm or to diagnose mass, infection, encephalitis, meningitis, they are using a contrast. You have to speak about the dye and the dye side effect, and at the end you have to get a consent.
Yeah, I think Dr. Wasim, if I mean, I understand what you're saying and I agree, but I think that this consent basically it will just be an informative consent. It generally is not a written consent because you'll just tell the patient that this is because already the patient had a CT tap, which is generally a contrast study. And so my point is that mostly these kind of scans they don't require a written consent. That's what we do normally, and there is no such thing as a written consent in these kind of scans. So I don't know if that's because that's the practice we follow in our hospital, that these kind of scans they are generally done without any written consent.
Okay, let's talk about renal protocol, CT renal protocol. I think there is contrast will be injected either in the phases of venous or arterial.
Yes, there is an arterial phase and a venous phase. So this is a contrast enhanced study. CT renal is a contrast enhanced study, but that CT tap which is already having, that is also a contrast induced study. It is not a plain, but generally this one is more specific for the kidney cancer, and that's the
Okay.
one generally
If you
recommended.
are injecting contrast and any complication happen due to the contrast, anaphylactic or even allergy reaction, what do you think? Is it important to get a consent before it?
Yes, I said that consent is not a written consent. It is just a
No, no,
verbal
even
consent.
written. No, 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 no. No, it's a written one. You cannot sign a verbal consent and to protect yourself. How you can protect yourself if you just inform the patient, this reaction might happen. Are you okay with that? Yes, doctor, I'm okay. Later on, the reaction happened and he complained against you and the hospital. How you can prove that you get a consent?
Hmm.
Any contrast need to be consented. It's a
Right.
rule. Yeah, okay. I think all the chat here writing about that triphasic scan, Dr. Ashima, makes sense. Yes, Dr. Aisha, triphasic CT has because I have one patient with kidney mass. They asked to do this. Yes, I believe any contrast in order not to have any doubt or any conflict with the patient later on if anything will happen. The problem is not the CT radiation. No, the problem in the contrast itself. I saw a lot of patients, they have reaction, and some of them went to allergic and anaphylactic shock. It was life-threatening condition. Some of them need intubation and admit to ITU. So why you keep this door open? Close it by a consent form or written consent. Okay. So any contrast again for any cancer or infection need to be consented. Remember that and pray for me when you remember it in the exam.
Right.
Okay. You are ready?
Yes, I'm ready.
Yeah. Last comment, Dr. Soha also wrote after explaining we are taking high risk consent written only. So it's not only risk, it's high risk consent. Yes, I agree with this. Yes. Here you go, Dr. Hisham. You can start now your scenario. Here you go.
Hello, hello, hi. My name is Dr. Khazer. I'm one of the doctors in the medical ward. May I confirm, are you Miss Catherine? Hello, hello.
Dr. Muhammad, you can
I
start.
I am Catherine, daughter of Miss Carol.
All right, okay. So I understand that you here and you want to speak about your mom's health, but before that, may I know that you also the next of kin of Mrs. Carroll?
Yes, I am next of kin.
All right, okay. Right. So before I start, obviously I want to hear that what exactly are your concerns?
Doctor, my daughter came since days here by throwing out some weight loss, and they did some camera scan for her. They told me there is some mild sore in her tummy, and everything is okay. But today I came to her, she is not okay, and I am not seeing any fluid beside any feeding, anything beside her. What does this mean?
All right, I fully appreciate your concern. So, right, so I understand what you're saying. So, have you got any idea that apart from this current problem, what exactly is the other medical conditions your mother is suffering from?
It's since a long time. I think I remember some doctor told me there is some problem in her memory and may increase by time. But this since a long time.
Right, right, okay. I fully understand and appreciate. So basically, as you already know that she had some problem with the memory and she has been on some medication for that. And this time she was admitted with uh, throwing up and also a weight loss, and it turned out that she has some soreness of the stomach, and otherwise it was okay. And she was started on medications, and that part has been better. Now coming on to the second part, which obviously is her chronic medical condition, which in medical term called dementia, in which she had that memory problem. So it seemed that there is a progression because it was expected that over a period of time, so there will be progression of a dementia and the memory problem as well. So I think that's what has happened with her, and at the moment it seems that she is quite advanced in her dementia. Are you getting my point?
Doctor, I am with you. What does this mean? She's dying?
Right, I fully appreciate that. So basically, as I said that these memory problem and these cognitive impairment or problem with her, which as I said that we call dementia, because it is a progressive problem over a period of time, it do get worse, and that's the reason that in your mom the things have been getting worse. She is not eating and drinking much, and that's why she has been losing weight as well. So I think that it's quite advanced at the moment. Are you getting my point?
Yes, doctor, I am with you. But she was taking some memory enhancer and she was, yeah, it's okay. Why we not giving it again, increase the doses?
Right, okay. I mean, obviously, because as I said, that this is a progressive problem, and we had a team meeting and we discussed your mother's case in that. And in that, we decided, and the team of doctors, they decided that most likely she has reached at a point where doing any kind of uh, treatment, which could be quite, I mean, kind of an active or aggressive treatment, which could potentially have certain side effects as well. And the benefit of those kind of treatment and further investigations, most likely she's not going to get much benefit out of all these things. Are you getting my point?
Yes, doctor, I am with you.
Because as I said that it is not. the dementia thing, it is not something which is a curable thing. So she was given treatment over a period of time just to see if she gets some kind of a control of the symptom. But at this point, it seems that it's already progressed into quite an advanced stage, and that's why the team has decided that she should not be for any kind of further aggressive therapy or any kind of further investigations or any kind of further test to diagnose her problem, because we know that this is how the progression generally occur in such patient. So the team has decided to make a decision that the best thing for her would be just to keep her comfortable and just manage her symptoms. Are you getting my point?
Yes, doctor. This mean you will live her die. If your mother you will do like this?
I fully appreciate and understand your emotions, uh, Miss Catherine. I'm not saying that we are not doing anything. So basically, we have a team of specialists, doctors, and also there are other people around the team, which is called a palliative care team. Have you ever heard about this palliative care?
No, doctor.
Right. So this is a dedicated team basically who works around in patients like your, yeah, like your mother, who have a very any kind of advanced disease, and they just make sure that the patient is being managed just so that the patient stays comfortable. So there are certain things which can be done, but there are certain things which might not be very good for your mom, and obviously the risk of carrying those things might be more as compared to not doing that. Are you getting my point?
Yes, doctor. But at least put here any feeding tube to help her.
Yeah, yeah, I fully appreciate because that's something I wanted to discuss because, uh, as I said, that this is quite an advanced problem. So generally, when such is the case, and obviously in that case, the life expectancy generally it dropped down significantly. Putting in something like a tube or something, there's another kind of a tube as well, which we do put in a by doing a camera and then put it in the stomach. So these are the things generally they are not. So there are options. So basically, these are the things we generally avoid because they may be a little bit discomfort, cause little bit discomfort to your mom. At the moment, she's able to have some small amount of fluids. So obviously, that's a little bit encouraging as well. Again, as I said, that we need to involve the palliative team and then ask their input on that as well. If they feel that she can benefit in terms of, because as I said that uh, the whole thing, and I'm trying to communicate to you is that the moment we need to make sure that she should be comfortable and there should be no such thing which could potentially cause her more suffering. So I think that's something which we need to avoid. Regarding that tube, as I said, that the tube which you're talking about, that NG tube which is passed through the nose, we can speak with that palliative care team and then ask their input and see if that's something which could be. But again, as I said, that at the moment she is taking small amount of the fluid, and through that tube, obviously it is only fluid which she can take, and we see that whether this is something which may be of any help or not. But I think I leave that decision to them, and then they'll come and discuss with you. Is that okay?
Okay, doctor.
2 minutes left.
Yeah, the other thing I just wanted to ask you, obviously, because we feel that she is quite advanced. So have your mom ever talked about you that how she will like to be in her last days of life? I mean, I'm talking just in terms of what what exactly are you feeling, because we need to discuss that as well in terms of the further care planning for her. So have she ever discussed about you with you or any family member or with the doctor about how she would like to be in the last days of her life?
Do you mean, doctor? I can't understand. She didn't talk with me.
Yeah, so basically, these are the patients. So we need to make an advanced care planning, which means that in the event while they are in the hospital or even at home or wherever they are residing. So if just in case, if they at some point if their heart start beating, if they go into some kind of a arrest of the heart, so we don't feel that compressing the heart will be of any benefit in this case. And obviously, that's something which we like to discuss with you because we don't see any chance of reversibility. So in medical term, we call it as a do not resuscitate order. So I think that's something I definitely want to discuss with you because your mom doesn't seems to have that insight or capacity to make that decision. And since you are the next of kin, so I think that's something which we need to discuss as well with you. Are you with me?
Yes, doctor, but this is too much
Ye-
on me. You're
Yeah, I
just
fully
telling
agree.
me my
Yeah,
mom is dying
yeah.
now, do not do anything. Then you are telling me something about
No, no.
restarting.
Yeah.
Can we postpone this to another meeting, please?
Yeah, sure. I think that we can have another meeting, and it doesn't mean that we are not doing anything. Palliative doesn't mean that. So she will still be getting those medications which she can have to help. It is only about those further aggressive treatment or interventions which might not be of any benefit. So that's why palliative does not mean that we'll stop all the treatment and let your mom die. So it is not like that. So if she get an infection, we are going to treat that infection. If she get any pain, we are going to give her pain medication. So it is just the management of the symptoms. Are you getting my point?
Yes, doctor, yes.
So I think that we can have another meeting as well, and obviously we'll discuss it further. But before we leave, I just wanted to ask you, any one of the family member having the power of attorney for health for Mrs. Carroll?
No.
All right. Okay. So in that case, obviously, because you don't have any power of attorney, so we just need to make the decisions uh, when we meet with you again, and obviously at the end, it will be a decision made in the best interest of the patient. So I think that's something which we do if we don't have any advance directive, and then we take it from there. Are you getting my point?
Okay,
Right. Any concern? Any other question?
thank you. Thank you.
All
Okay.
right. So I'll arrange another meeting, and then we'll take it from there. All right.
Okay, doctor, thank you.
Okay. Thank you very much. Thank you.
Okay, time is up. Usually, I'm adding 1 minute extra to finish the address the other concerns. But in exam, no excuse. Once they mention time is up, you will get out of this room, going to the other station. Okay. So be sure that you cover everything before the time is up. Once you are here, 2 minutes left, you have to discuss the concerns if you want to do closure of the scenario, and that's it. Let's go to the comment, Dr. Muhammad. Then I will
Yes,
complete.
yes, doctor. طبعا دكتور هشام did very well and cover most of the point that in the calibration. But one significant point to notice, you are talking too much and too much sentences before confirming that the patient, the surrogate with you, take care of this point. Be more simple, more target, يعني to not spend the time. This is advice for me also يعني. Let's start by طبعا the main point it is end of life care, not only palliative. He didn't mention it clearly. Sometime the exam he will not mention, like last case CT renal and it was CT contrast. So from the beginning, he written for you she is anxious and not happy. So you'll be ready that she will be attacking the hospital, attacking you like this. First point, the dementia. You talk about it, but you didn't mention the main definition. This is a progressive, irreversible damage of the brain cell. خلاص, this is will give a hint to her daughter. This is uh, the term that her brain is ending, and this mean as you see here that this mean she started to not remember anyone, even not remember to eat. And I am so sorry, it is not curable. Even that medication she's taking, it is not a cure. And I am so sorry to tell you, she may die anytime. This is like partially breaking bad news to finish the case from the beginning and to prepare her to the next hard formation or hard news. Then I will tell you about she will die. يعني she is the one telling you she will die. You can start it from the beginning from yourself. I'm so sorry to tell you like this. I'm afraid to tell you. This is advanced. and the definition of the dementia, and directly we'll start that the we did everything. She will tell you she's coming by vomiting only like this. Yes, appreciate your concern. We did everything for her, image, camera, everything. There is nothing of concern, and this is related to her original disease, that's dementia. And this is late stage of her disease. You can at this time start to tell about palliative end of life together. That there will be a palliative team there to, as you mentioned, from pain doctor, specialized nurse, mod doctor, everything will be there, only to make her comfortable and to avoid any distressing for her. At this time, she will tell you to put a tube and help her by feeding. You can ask her, do you think that if you put this tube, it will help her brain to come back? We don't think so. And as you mentioned, she's taking some little fluid, and like this. This and it was very good for you, very good from you, really. And you can encourage her. Family will be beside her. But any other, the consultant and all the team, since that any of this intervention like tubes like this, it will only do the like life sustaining for her. It will only make her more suffer for her and more suffer for the family. We can keep her on this in the oral fluid as she is taking, and avoid anything to make her more distressed and more pain. Okay, يعني you can go directly from definition. She's dying. We'll start palliative. All other intervention like tubes, even medication, even يعني you started. You were very good, and then you come back to the palliative. يعني you go to the end of life, then you come back to the palliative. At this time, even medication, even oxygen, even everything, it will only sustain the life for suffering. No benefit, no, the patient, the brain will not come back. Then you can, some sympathy. I know it is difficult for the deep lover of hair, and we know all this information difficult and this hard news, but we are doing the best interest for her comfortable end of life. You can mention this line at the end. We are doing this the best interest and comfortable end of life for her. At this time, she will be calm, خلاص. She know that you are telling her she's dying and no more intervention, even medication, even antibiotic. It will not help because the main disease is fatal and she is in the late stage of it. So definition, and to know that it is in the late stage and she's dying, then we start palliative to make her comfortable, but no more intervention. We'll let her die in peace without any pain or any distress by tubes and medication and like this. Sometimes I think we can take her at home. Some concern like this. We can take her to home. As we mentioned, usually we'll assess her and we'll see if she is fit with, we'll discuss with all team. If she is fit to go home, we'll allow, and we'll discuss this later with you. طبعا a very important thing, you did well when you ask about any wishes, any assigned decision on behalf to take some decision regarding advanced. If you have time to ask about DNR, it's okay. But the most important here about the support, you didn't mention anything. Anyone depend on her, anything, any support you need at home, any support for the family, like this. Then you can give her some website leaflet to read more and more about this issue. And until the next meeting, we will discuss about the advanced planning for her regarding if the heart suddenly stopped, we will see the best interest of her to not to do this CPR resuscitation or DNR decision. If you have time, this is the last line. But the support more important at this issue. Okay, Dr. Hisham, you did
Yes.
well. We need some adjustment for the.
I just want to ask you one question, Dr. Mohammed. That patient was 84 years old. Even that, then we need to ask about anyone depending upon her for support with advanced dementia. So that's why that was something which was in my mind, but I mean, voluntarily I held back that thing so that it didn't backfire. So that's the only thing I.
Dr. Ihtisham, the family depending on some financial issue regarding her mother. So they may be dependent on them, on their financial support. So, and I think the examiner is not testing you for this case. He's testing you how you manage all the situation in such a case. Maybe someone 60, 70, 40 like this, and he's dying like this. He will see the main lines of your communication regarding this case. And you will put what is important before. Yani you are here, started patient, she is coming as vomiting only, then become dying and palliative, then end of life, then you will start to take, you will not her start her heart. So difficult for her. At least some sympathy and some support.
Mm.
It will. I think it's very important. Maybe Dr. Bassem comment about that.
Yes.
Another thing, yeah, I want to ask one more thing because I didn't take it, honestly speaking, I didn't take it immediately as a case of end of life.
Yeah, let me
I
comment on this, Dr. Hacham. So
Okay.
I will be agree with Dr. Muhammad regarding the support. At any scenario, while discussing at the end, 2 minutes left, raise the point of support, not for the financial, even the emotional support. This family will lose one of the precious grandma or mother, so they will be sad at any time. Okay, they are linked to her at all her life, and they are dependent or not dependent. Sometimes emotionally, that's enough. Okay, so you have to support as the social support, whatever the age. So I agree with this point, but really I disagree regarding the end of life. Here, what's written in the scenario was clear. It's palliative care. So I will not go to the palliative, so to the end of life as a clear message. The task here is clear forward to the palliative one. So I will talk about palliative. And by the way,
Yeah.
palliative sometimes you can speak about no resuscitation, DNR, withdrawal of some medication, but you will not talk about end of life
Yeah.
as long
Yeah.
as it's not
Yeah.
mentioned. Yeah.
Yeah,
So
Dr. Basin, the reason is that obviously because the reason I'm saying this, we do get a lot of patients who are on palliative care for say 1 year or 2 years, and they might come in with infection. We do treat them with antibiotic. They might require oxygen. We do, and even we do at time the palliative team, they give palliative oxygen as well, just
yeah,
to
yeah,
palliate the symptom. So because this patient in the scenario it was written, the patient
exactly.
is sitting and drinking some water,
Yeah,
yes, advanced dementia, but there was no mention that the patient is that bad that we are going
or dying,
for end of,
not
yeah,
mention
end of life,
or
yeah,
dying.
yeah,
Yeah,
yeah.
yeah, you can read the scenario again, Dr. Muhammad. It's clear. Palliative care is decided. So I cannot say this is end of life scenario.
Dr.
Okay.
Bassem, I told you before, I am not bringing يعني 90% of my cases coming with calibration. I can send you later on the calibration on the. So I am sending the
Calibration
calibration
as
for.
feedback, you mean? Feedback?
Wallah, I don't know, but it's a very organized
Calibration
calibration.
from whom? If from mentor, I don't believe any mentor, by the way. If you are talking about mentor, I don't believe any mentor unless
Okay.
he's examiner. Sorry if you yeah, if I'm saying like that, but the mentor usually giving advice, but they are not examiner. They don't know what the examiner are judging. Okay, some situation and some scenarios they are judging from their point of view, but in the exam they have different view and the different judgment from the examiner. So don't, this is my beliefs, don't trust any mentor. Yes, they are helping, but they are not with you in the exam unless they have solid feedback with the same scenario with the same details, so you can do so. If the scenario written there palliative care. Why I should say end of life care? You got it?
He
It's not
didn't
something
mention
hidden.
palliative care, Dr. Bassem. He didn't mention palliative care. He
No, 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 no,
mentioned
no, no,
no
no, no.
other, Dr. Bassem, the scenario clear. No other intervention. خلاص. No other intervention, medicate, nothing.
Doctor,
This
No, it is
man,
written. It is written in the
act-
scenario that
and
palliative
that
care is the
palliative care
best
is the
approach.
best
Yeah.
approach.
Yes.
The
It
line
is.
before the last line in the first paragraph. I review the scenario before saying that, Dr. Muhammad. If there is clear end of life, I will say it. I'm not against your advice.
And
Okay. By the way,
even if I mean if the clinical scenario is such that the patient is very sick and
yes,
then
but
there's a
the task is to
then
talk about this. I will talk about this. Even the scenario the patient is dying. What my
yes,
task to do, I have to do. I'm not talking about the situation or the condition of the patient. I'm talking about the task. Even the patient is dying, but they mentioned to me palliative. I will talk about palliative. Okay. If the patient is very good and they tell me, or the task is to talk about the end of life, I will talk about end of life. What I mean, the task is a clear task you have to fulfill. You got it, Dr. Muhammad. I'm so sorry, but you can read the scenario again. Read it.
no,
It's clear.
Dr. Bassem, no problem.
You got
We
it.
have
You saw the sentence.
yes,
huh?
it is about palliative care,
Yes, yes,
that the
there is
decision is
something
about
palliative, but I don't
palliative
know.
care. And it
As
seems
I
that the
said.
patient is stable, not going, I mean, immediately. It doesn't seem that the patient is immediately dying. Yes, she might
Yeah,
die in 3 months,
yeah,
she might die in six
yeah,
months, she might live for another year, but the task is written, palliative care is the
yeah. This is
best.
my point. It's not the
Yeah.
situation or the condition. It's about the task. The clear sentence. The palliative care is the best approach. Full stop. So this is the task. So I don't think you have to talk about end of life.
But
Let's go.
one point, Dr. Bassem,
Yes, yes.
Dr. Ihtisham started by palliative and again told the patient, the relative, that we will discuss with the palliative team if we can put feeding tube. No, no
No, no. What?
intervention again, no pain for the patient. خلاص. He can take the food as he can. وخلاص. I think this is the right thing. Don't
Okay.
give
If
any
as aggressive management, yes, you can say no intervention, no tubes will be inserted, but it's one of the option. Why not? It's
Yes,
by the way,
palliative.
yeah,
Yes, we do
yeah,
palliative nasogastric, but I told
yes,
the
yes,
surrogate patient already is taking sip of water, so
yeah. So you can,
nasogastric will not. But I said
yeah,
that I'll involve the palliative and take their input. But at the moment, that's what I feel. NG can, but if she asks about PEG tube, I'll say big no. I'll say no, no PEG tube because it is an invasive. But NG can still be done,
yeah, yeah,
and if not, if the patient is not, then we can say that it will be a risk feeding patient. At the moment in the scenario, it was not mentioned that there was any swallowing problem. So if there is no swallowing problem, so even no point in going through that NG as well. But as I said,
yes.
that NG could be a part of palliative as well.
Yes, yes, I agree with this. So NGT is not something invasive, semi-invasive. The tube will pass, only the patient will feel it in the nose. After that, he will not feel anything. Then we can feed the patient through it. Or the patient, if he can tolerate any sip or fluid, he can drink. One more point I want to discuss, and this is again is Dr. Ihtijam, when he mentioned about the dementia. Dr. Hisham, you mentioned the memory only. Dementia means even the cognitive function. You mean or you mention only the memory impaired or affected. But dementia means even the cognition. The patient will not recognize his surrounding, his family members. So you can evolve to the definition, okay? That's why. But what the other meaning, what definition you mentioned that it's progressive disease, so the mother will not be improved. Whatever you are giving, enhancer or any medication, will not help because this is and progressive or a progressive disease. This is my comment. So let's have the feedback from others. Regarding the skills, you cover all the skills. The DNR advanced directive, you discuss it in a long time, which is spent around 2 minutes, which is the time of concerns. It's easy thing. Any wishes your mother expressed while she was okay? No, doctor, she didn't. Why, doctor? Is she die? You can say, I'm so sorry. Her condition now is not as before, and we are thinking about to respect his wish, her wishes whatever she wish, we can follow. If she wish to go home, we can respect these wishes. We can send her home in order to sit with her family at the end of her life or at the last couple of minutes or weeks or months according to the duration. But don't explain a lot. You said if she express anything which can we can help in this. I think it's simple only to say whenever she express something, please let us know. We have to respect her wishes in the coming days. Okay, which is called advance directive. You want to show the examiner that you ask about it, and anyone on behalf of her, he can take decision for her management plan. Let us know. It will take only 30 seconds. Don't spend a lot of time to speak about the advanced directive. Why? Because you waste the time in that and you didn't mention the support. However, you write in your paper that you have to talk about the support. You got it?
Yes, yes. Thank
Yeah.
you.
Okay, thank you, Dr. Hisham. Anyway, both of you are really professional, perfect. At least you will not get less than 12 out of 16. Okay, and let's talk.
Hope so, Dr. Bassam.
Yes, no, no. You have the way how to communicate, respecting the talk, but give it chance. As Dr. Ahad wrote, give a chance to the surrogate to talk. Not only you are the one talking. It's a conversative one. Dr. Ashima, I think ask about daughter social. If need any help at home, may she has a child at home and she needs to spend more time with her mother. So you can ask anyone dependent or anyone need a support. General question. Don't specify the supports. Just mention anyone at home need a support or who was dependent on her. Yes, doctor, I am the one. I have kids. Whatever the support she will ask, you can say we will respect that and we will refer you to the team who can help you in this regard. Dr. Ahmed Mustafa, I think you should trust the scenario exactly. Whenever written, trust the scenario. End of life, talk about end of life. Palliative, talk about palliative. Don't add from your side something which is not in the scenario. This, I think, this is the way of the mentors. Sometimes they are trying to do some decoration to the scenario, but it might be against your mark, or it will minus you. We will open the discussion quickly. Anyone has any comment? I am done with my comment for both of you. Anyone want to add any comment? Dr. Ahad usually are commenting on this scenario.
Regarding my
Yeah,
scenario,
yeah.
if it is CT contrast, how will be the mark? I think كده في at least 3 4 mark will be missed because the procedure
Clinical,
the
yes,
die.
it will be in the clinical judgment
Mm,
or the
right.
consent form as a clinical communication.
I think
Cli-
that, sorry, I think that my understanding is, Dr. Mohammed, if you do the way you did that, I think most likely you are going to get 14 out of 60,
yeah,
16, if not more. So, because I think that they will not completely say it was unsatisfactory. So, even if it was just in one,
borderline.
yes, so
Yeah,
they will put, so I think you will still get 14 out of 16, if not
exactly.
16 out of 16.
I said 12 is the least mark you can get, both of you. But back to the
Consent have
consent.
to in my mind because if no trust, no need. This is sure. The other thing, the patient himself tell me, خلاص, I will go on to that city. He give me verbal approval. That's
No, no,
why
no.
I didn't mention.
Any cancer, you have to give a contrast. It's a
I
rule.
know, I know the protocol of cancer pre and
Mm-hmm.
enhanced
Mm-hmm.
stage. But that's why when the beginning I asked, this is biopsy, what type? So it was
No,
strange.
but they
Renal.
want to confirm renal mass means a cancer, so means a contrast in brackets. Okay.
I afraid to mention maybe he don't want contrast. If I mention patient, he will be against me. That's why it is not clear. يعني.
Okay, let's hope in the exam will be clear regarding the contrast. And
Mhm.
I will tell you also something very important. If you speak about consent with the CT, it will not harm the patient to sign it. But if you got the opposite, if you do the opposite, you didn't talk, you don't take the consent and there is contrast and something happen, it will be against you. Is it clear? So imagine if you do so without consent and there is reaction from, and there was a contrast, and reaction happened. What will happen to you? Legally, you will be asked and blamed why you didn't get a consent. If you do the consent and you went to the radiology and you gave him the consent and he told you, no, doctor, we don't need a consent form for this CT. So you will cut the paper and we go back to your department. This is my point. In the exam, if something need to be consented, please consent it. The consent form for any contrast is something to be a minus if you didn't mention. And any cancer need to be given a contrast to diagnose it. This is what I know, and every one of you know in the practical life. Any contrast or any cancer, you have to give a contrast for the enhancement. Okay. So I hope it was clear. Good session by Dr. Hacham and Dr. Muhammad. I think Dr. Hacham, this is the last session, right, before your exam. So we'll pray for you. Best of luck, Dr. Hacham. You have the good knowledge, good confidence. You are calm. Just give a chance to the patient to talk. Follow scheme approach. Be organized, systematic, and hopefully the exam will be easy for you. The same for Dr. Muhammad, but Dr. Muhammad will be with us tomorrow, right? As a short clinical. So last question. Anyone has a question before ending the session? Yeah, Dr. Aisha, wishing you the best. Thank you, Dr. Aisha. Anyone want to add any comment before ending the session? So clear for all. Thank you, Dr. Muhammad, Dr. Sham, and all attendee. See you tomorrow, inshallah, with the short clinical station day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa
Thank you very
barakatuh.
much. Thank you. Thank you.
Thank you. Thank you. Best of luck.